Hello and welcome to today's noon conference co-presented by Modality and AAWR. The AAWR was founded in 1981 to provide a forum for issues unique to women in radiology, radiation oncology, and related professions. The association sponsors programs that promote opportunities for women and facilitates networking among members and other professionals. AAWR has membership opportunities for those who have completed their training, members in training, and international radiologists. Learn more about their mission and membership at aawr.org. We're thrilled to partner with AAWR on these lectures as part of our shared commitment to advancing and supporting women in radiology and transforming the way radiologists learn and thrive. Today, we are honored to welcome Dr. Amy K. Patel for a lecture entitled Breast Density Insights and Cases from Past, Present, and Future. Dr. Patel is a board-certified breast radiologist, medical director of the Breast Care Center at Liberty Hospital, and associate professor of radiology at the University of Missouri-Kansas City School of Medicine. She is immediate past president of AAWR and is actively engaged in numerous societies, publications, and speaking engagements. Dr. Patel is passionate about women's health, advocating for equitable breast care and expanding access to care for all patients, and we're so glad she's here today to share her expertise. At the end of the lecture, please join Dr. Patel in a Q&A session where she will address questions you may have on today's topic. Please remember to use the Q&A feature to submit your questions so we can get to as many as we can before our time is up. With that, we are ready to begin today's lecture. Dr. Patel, please take it from here.
Thank you very much for having me today. I really appreciate it. I'm going to go ahead and turn off my video and share my screen as I have a lot of content and there's a lot to get through. And then at the end, we'll leave some time for a Q&A. If you have any questions, I'll turn my video back on. So today I'm going to talk about a really hot topic, particularly in the field of breast imaging, not just, in the United States due to some recent developments with the FDA and Mammography Quality Standards Act, but really all over the world. So we're going to talk about breast density today, and we'll talk a little bit about, how did we get to this point with breast density, where we're going, where we are now. And again, if you have questions at the end, happy to try to answer them to the best of my ability. These are my disclosures. So today we'll analyze the origins of the Mammography Quality Standards Act, including its current state. We will evaluate the future of MQSA regulations when it comes to breast density reporting. We'll develop a comprehensive understanding about breast density, including supplemental screening modalities and guidance on communication with patients and referring providers. Analyze potential implications about breast density legislation and federal regulations that may have on patients and practices, including insurance coverage, possible disparities as well, and discuss some maybe educational opportunities that we could all impart regarding breast density. So what is breast density? So breast density refers to the attenuation of the X-ray beam in concert to the degree of breast fibroglandular tissue. So we know that there are 4 categories of breast density that we report, and I will go over those in just a moment. And basically, when we make that determination, it's categorized on the basis of the densest area of tissue, which could obscure a lesion. Now, there are those in the field that are subjectively looking at the breast and giving one of the 4 assessments, but now there, and has been for a few years now, software that calculates volume density percentages to take away that subjectivity in assessing breast density. So this is a fatty breast, as many of you know. So whenever we report an exam and a patient has a fatty breast, obviously we use the BI-RADS vernacular, and the language we use is the breasts are almost entirely fatty. And mammography is highly sensitive in the setting of a fatty breast, so about 88%. So we know that on mammography, the breast density or the dense breast tissue looks more white on a mammogram, and fat is more gray. So you can see here that, we have a lot of gray here. So if there is a cancer that is going to be, popping up here, we're more likely to see it because there's less of that dense tissue or that white on the mammogram. Fatty breast density comprises about 10% of the general screening population of United States women. Then scattered is where we report there are scattered areas of fibroglandular tissue. So now we're starting to get more wisps of the dense tissue or the white on the mammogram. This comprises about 40% of women of the general screening population of United States women. There are heterogeneously dense breast tissues where now we're starting to see that more white on the mammogram, more fibroglandular tissue. And the language we report are the breasts are heterogeneously dense, which may obscure small masses. This comprises about 40% of the general screening population of United States women. And then we have extremely dense, where the breasts are extremely dense, which lowers the sensitivity of mammography. So you can imagine if you're looking at a mammogram and you see this very dense breast, you see all of this white, it can be really hard to see a cancer. And whether it's a 2D mammogram or digital breast tomosynthesis or a 3D mammogram, it still could be hard to detect a cancer in this sea of dense tissue. This is the sensitivity. The sensitivity of mammography in this category is the lowest, about 62%. This comprises about 10% of the general screening population. So this kind of shows the four categories: fatty, scattered, heterogeneously dense, and extremely dense. Now, about 50% of the female population in the United States over the age of 40 have dense breasts. So a significant number do. Most patients in the United States fall between these two categories in the middle, scattered and hetero, but about 50% of women do have dense breasts. So it is very prevalent. So we've already talked about this, but as the sensitivity of mammography, it essentially decreases as the density of the breast increases. So that's why your sensitivity is lowest in an extremely dense breast tissue. And it's important to note too, and we'll get into the weeds about breast density and being a risk factor for breast cancer. But if you are a woman who has a fatty breast on this end of the spectrum versus a woman with a extremely dense breast on the opposite end of the spectrum, your risk of breast cancer is 4 to 6 times higher than the patient with a fatty breast. So like I like to say, breast density matters. So after certain age and genetic mutation carriers, or certain genetic mutations such as BRCA, breast density is the biggest risk factor for breast cancer. So breast density matters. So we feel that this, the science of this is cumulative exposure to growth factors and hormones in areas of high mammographic density. They may stimulate increased cell division in epithelial and non-epithelial cells, which may explain the increased risk of breast cancer that we see in these women with higher ratios of fibroglandular tissue, comparatively speaking to fatty breast tissue on mammography. We know that high breast density is associated with a larger tumor size, high histologic grade, lymphovascular invasion, more advanced stage, and positive lymph nodes. There's also the masking effect of breast cancers that also contributes to increased risk, where we see dense tissue, the cancer is hiding, we're not able to identify it. And then there's a lot of great research on breast density actually happening around the country, but particularly at Washington University in St. Louis. And they have recent research revealing that younger women with a family history of breast cancer are at higher risk of developing dense breast tissue and mammography, meaning higher risk of developing breast cancer. We also are finding that twin studies support that mammographic density is heritable. And there was an article from Boyd and colleagues that showed that correlation between monozygotic twins was approximately twice as strong compared to that between dizygotic twins. Genetic factors explain the majority of variation in breast density in their study, with heritability estimated to be as high as 75%. Brand and colleagues also demonstrated that at least 25% of the variance of volumetric mammographic density is explained by common genetic variants. So we are seeing a genetic predisposition to breast density. So this leads me to supplemental screening and modalities. So why, are we in the field of breast cancer talking about trying to improve supplemental screening and, suggesting or encouraging patients to do it? Why? Well, we've already talked about it. As the breast density increases, particularly on mammography, the sensitivity decreases. And so dense breast is a major limitation of mammography, whether you have full-field digital mammography or 2D mammography or digital breast tomosynthesis or 3D mammography. And we've talked about the mammographic density is a independent risk factor for breast cancer. So there's supplemental screening tools out there, which we'll talk about. The first one is digital breast tomosynthesis or 3D mammography, which isn't really considered supplemental now, but nevertheless, ultrasound, MRI, both full and abbreviated protocols, molecular breast imaging, and contrast-enhanced mammography. So currently, many of us know that there's robust research out there that demonstrates that digital breast tomosynthesis improves cancer detection rates while reducing false positive and recall rates. The American College of Radiology has also deemed DBT as no longer investigational. We know the advantages. Many of us who are breast radiologists who are interested in the field of breast imaging, where on digital breast tomosynthesis, we do have better delineation of margin lesions, lesion margins rather. There is a reduction in the recall rate. We're seeing a higher positive predictive value, a lower number of unnecessary biopsies, and then also less breast compression than 2D mammography, which patients really like in terms of the comfort factor. And, we know that particularly the recall rate reduction has been wonderful so that women don't have to come back for additional imaging due to a finding that, initially was likely, superimposed overlapping breast tissue that we would, see a lot, particularly in the era of full-field digital mammography or 2D mammography. The disadvantages have really improved with the new iterations of digital breast tomosynthesis. Artifacts used to be an issue, which have really improved, particularly with what were called pseudo calcifications, where we would see what could be calcifications on a screening mammogram. The patient comes back for additional views. The calcifications aren't there because they were not real in the first place. That's really improved with the new iterations of DBT. The scan time has also significantly been reduced to be comparable to a 2D mammogram. So, the disadvantages have definitely improved from a patient standpoint. Longer interpretation time for radiologists, yes, they typically do take longer, but now there are systems out there where instead of 1 millimeter slices, there's now 6 millimeter slices with 2 to 3 millimeter overlap without loss of image integrity, which can also help with the interpretation time. So how is DBT covered, screening covered by insurance? So all states cover DBT through Medicare currently. Medicaid covers DBT in most states. And then private insurance coverage is now covering in many, many states. And we were fortunate in Missouri to pass DBT legislation for screening back in 2018. So switching gears to whole breast ultrasound or automated breast ultrasound. So, this modality of ultrasound has been shown to catch slightly more cancers, but also has a higher recall and false positive rate. And there really needs to be more randomized controlled trials to prove the efficacy of screening ultrasound. Akron 6666 study showed incremental cancer detection rate of about 2 to 3 per 1,000, but twice as high recall rate as mammography and a lower positive predictive value than mammography. And then adjunct ultrasound resulted in biopsy in 5% of women compared with 2% referred for biopsy based on mammography alone. And then only 7.4% who actually underwent a biopsy were found to have cancer. 3.2 occult cancers were found in a study per 1,000 screens after Connecticut 941 passed. However, that was a bit skewed in those results because they used a mixed population with both screening and diagnostic. And so you're going to have a higher probability of malignancy if you have a mixed population than just screening alone. So Weigert and colleagues revealed whole breast ultrasound for women with mammographically normal but dense breasts yielded about 3.8 cancers per 1,000 screens, a PPV of 9%, and a specificity of 96%. So ultrasound is less costly than mammography. There's no involvement of radiation. However, it can be very time consuming, particularly if you are a facility that offers whole breast screening ultrasound that's handheld, that the technologist does, can, obviously take more time to perform the exam. There's additional costs associated with that and high frequency of short-term follow-up recommendations. So this is a case of a 58-year-old with a palpable on the left breast. You can see here the patient has heterogeneously or some may say extremely dense breast tissue. You can't see really, nothing's really glaring at me in terms of a malignancy. And then the patient ended up having a diagnostic ultrasound, and you can see here that there's a conglomerate of masses here. A regular hypoechoic mass is greater than 5 centimeters in size at 12 o'clock of the left breast, 3 centimeters from the nipple. Patient underwent ultrasound core biopsy, and pathology yielded invasive mammary carcinoma and DCIS. So switching gears now to full breast MRI. So full breast MRI has a lengthier protocol. It does vary per institution. A patient may not be covered by insurance even if they're above average risk. So there's many states now that have passed high-risk breast imaging legislation, and with that, supplemental screening is covered, such as those patients who want full breast MRI or ultrasound, but not all states are covered. So it does vary significantly, even per institution and geographically, in terms of what's available to the patient as well. So breast MRI, however, has the highest cancer detection rate of all breast imaging exams across all breast density categories. It's very sensitive. Breast MRI can really see past that dense breast tissue that we aren't able to see past at times on mammography and on ultrasound. Although most evidence demonstrates using breast MRI for screening the highest risk patients, there is increasing evidence that MRI is useful in screening women who are average or intermediate risk. And so hence the advent of abbreviated breast MRI, which I'll talk about in subsequent slides. So abbreviated breast MRI was introduced to reduce complexity and cost of the full MRI, equating to access. So multiple studies have confirmed equivalent diagnostic accuracy of abbreviated to full MRI protocols. And so this has really led to abbreviated breast MRI being utilized for those with dense breasts, particularly of average or intermediate risk for breast cancer. So abbreviated breast MRI is a brief screening examination that can be used to supplement annual screening mammography, particularly for those with dense breast tissue. And it's important to remember that abbreviated breast MRI is a supplemental screening tool, and it complements, it does not replace a mammogram. And we know this, why? Because on mammogram, we might see findings that we might not be able to catch on MRI. For example, subtle microcalcifications and an early grade DCIS that may not be seen on MRI. Alternatively, on MRI, we might see a little focus of enhancement that ends up being an invasive cancer that we would not have seen on mammography until it was much larger. But in the end, abbreviated breast MRI is a supplemental screening exam that complements mammography. Mammography is the only screening tool that to lower breast cancer death rates. So with the basics with abbreviated breast MRI, it relies solely on one pre and one post contrast sequence. So we have, less information than a full MRI, but we still have pre and post contrast sequences. So we can create a subtraction sequence, which can really help us aid in seeing, if there is something suspicious on MRI. It has been developed to reduce scan time, interpretation time, and make breast screening more accessible and affordable, like we talked about. There is a lack of delayed post-contrast series that limits conventional kinetic analysis, but there are certain things that you can work on with your vendor to create a kinetic component so that you have some sort of kinetic analysis to help you aid in your diagnosis. So looking at abbreviated breast MRI and ECOG Akron 1141, looking at 8 studies, the abbreviated breast MRI sensitivity was 95% versus full MRI sensitivity of 98%. So very, very commensurate. And then the DENSE trials, which are randomized controlled trials that study the effects of supplemental breast MRI on the incidence of interval cancers in women with extremely dense breast tissue. Looking at trial 1, supplemental MRI screening in women with extremely dense breasts not only yielded 16.5 cancers not detected at mammography per 1,000 exams, but significantly lowered the interval cancer rate. Trial 2, incremental cancer detection rate of MRI over mammography in the second round or the incidence round was lower than that in the first round or the prevalence round. And the false positive results were also lower. And trial 3 is currently underway. So the abbreviated breast MRI protocol, it ranges time-wise depending on your institution. At our institution, our abbreviated breast MRI protocol is approximately 11 minutes. And patients who benefit are the ones who are average or intermediate risk with dense breast tissue, as I talked about before. However, we do have some patients that, still, even though we did pass above average risk breast imaging legislation in Missouri in 2020, they may not have insurance through Missouri. And so those patients may still be denied by their insurance carrier if they don't cover breast MRI in patients who are high risk. So sometimes we'll have patients call and say, I'm a high risk, I want the MRI, my insurance is denying it. And then in those situations, we may say, we'd rather you have MRI than not have it. So we can, make concessions and have you do the abbreviated breast MRI, so you have that access to some sort of MRI. However, we still strive for those patients who are above average risk to receive the full MRI, alternating with mammography every 6 months per ACR and NCCN screening guidelines. However, abbreviated breast MRI, like I mentioned, it can be really cost effective for access. Currently, unfortunately, in the United States, abbreviated breast MRI does not have a billable code. So if you do try to push this through insurance, usually people will submit the claim with a G modifier code attached. So there's sort of like a discounted, aspect to this, given that it's not a full MRI, but it's very hit or miss for reimbursement. So most institutions right now offer abbreviated breast MRI as a cash pay, and many institutions offer it at a lower cost just to cover the cost of the contrast and the labor, just so that patients, have access. So abbreviated breast MRI ranges from $250 in the United States to we at our institution charge $325. There are other institutions that charge $400, $500. So that's kind of the range, about $250 to $500 typically. So, like I mentioned previously, multiple studies have now demonstrated similar cancer detection rates to full breast MRI of approximately 15.5 to 18.1 per 1,000 exams, opposed to 3D mammography alone, which is about 4 to 6 per 1,000 exams. A recent article from Weinstein and colleagues reported a cancer detection rate of 27.4 per 1,000 in women with dense breasts and a negative DBT exam. So that's very, very high, and showing the power of the sensitivity of this examination. So some institutions have developed robust MRI high-risk screening programs with the use of abbreviated breast MRI. However, as the field implements wider use of this tool, a standardized abbreviated breast MRI protocol truly is needed. So future steps will likely include development of universal abbreviated breast MRI protocols, as well as quality measures and guidelines. So when we look at pros and cons of MRI, MRI is more sensitive in detecting cancers than mammography and ultrasound. It is not limited by breast density, which is huge. There is no involvement of radiation. It preferentially detects higher grade lesions. However, with MRI, there is a higher recall rate. So Akron 6666 study, it showed 14.7 per 1,000 cancers found. However, a high false positive rate. 7% of women in the study had a biopsy based on MRI alone, with a cancer detection rate of about 18.6%. There's a need for IV contrast material. And of course, it is less tolerated, particularly if the patient has a full breast MRI. It can be quite challenging for a patient to lay on their stomach, depending on how long that full MRI protocol is at the institution. They might be claustrophobic. It's just, an uncomfortable position to be in. So this essentially compares the full protocol MRI to abbreviated breast MRI, and just particularly demonstrating that the sensitivity is very commensurate across multiple studies in the literature. So this is a 35-year-old high-risk female. She presented for screening MRI. She had a negative mammogram. And here you see in her left breast, she has a conglomerate of masses, and the patient underwent second look ultrasound. We found the masses. Ultrasound-guided corneal biopsy was performed, and pathology yielded IDC and DCIS, but not seen on the mammogram. So switching gears now to MBI, or molecular breast imaging. So MBI uses small gamma cameras in a mammographic orientation to provide high-resolution functional images of the breast. So technetium-99m system maybe is currently being utilized as it's an approved agent for breast imaging. So the advantages are increased sensitivity when combined with screening mammography versus mammography alone, and a higher sensitivity for detecting small breast lesions, about 82% for lesions less than 10 millimeters in size. The disadvantages are a high radiation dose with the injection of technetium-99m systemibly compared to mammography. So when you look at the effective dose from 20 millicuries of technetium-99m, it's about 6.5 millisieverts, but by comparison, screening mammography is about 0.721 millisievert. So the whole body dose in one visit having MBI is non-negligible, whereas with mammography, it is negligible. There is a long imaging time. So the patient is, 4 views are obtained, just like a mammogram, but each view, the patient is in compression for 10 minutes. So it is a bit longer, much longer than the seconds that you undergo when you undergo a mammogram. And it is poorly covered by insurance currently. So this is a case of a 43-year-old high-risk female. She had a negative mammogram, and you can see here she's pretty scattered density. She's not particularly dense, but it was called negative. And the patient had a subsequent MBI exam. And there was a focus of increased uptake here in the central left breast. So the patient had a second look ultrasound. You can see here a 1 by 0.7 by 1 centimeter irregular hypoechoic mass with microlobulated margins. It has an anti-parallel orientation. The patient underwent an ultrasound-guided corneal biopsy, and pathology demonstrated invasive mammary carcinoma with mixed ductal and lobular features, grade 2 of 3. This is another case of a patient who underwent a mammogram. And you can see here that there's nothing that really pops out at you. Patient ended up having MBI, and you can see here that there's increased radiotracer accumulation. The patient ended up having 11 centimeters of disease, and biopsy was performed after a second look ultrasound revealed the masses, and this came back invasive lobular carcinoma. So switching gears now to contrast-enhanced mammography. It's an additional vascular-based imaging modality that improves cancer detection by identifying the angiogenic effects associated with tumor growth. So there's more mounting evidence that CEM demonstrates improved diagnostic performance characteristics compared to digital mammography alone, with better lesion detection and improved sensitivity and specificity. So the pooled sensitivity and specificity estimates for CEM and the diagnosis of breast cancer are 0.89 and 0.84 respectively. Sung and colleagues demonstrated improvements in sensitivity, specificity, and a negative predictive value in the screening setting in 858 women with at least 1 year of follow-up, and 6 of 14 cancers were detected only due to contrast enhancement. So the availability also of contrast-enhanced mammography provides an alternative screening method for women who may meet guidelines to receive breast MRI, particularly let's say from high-risk groups, but might have a contraindication to having an MRI. So maybe they have a metallic implant. They have weight limitations. They're just claustrophobic. CEM can also be useful for just any diagnostic dilemmas you might have. Let's say there's a patient also that has a history of breast cancer. You've just diagnosed them. She really needs a breast MRI for extent disease. She can't handle the exam. We need to know if there's any other disease in the affected breast, the contralateral breast. So CEM can be a great alternative in that situation as well. Current generation mammography systems are often delivered with contrast-enhanced mammography capabilities as well as biopsy capabilities, and that really alleviates equipment acquisition costs and space allocation needs. But the primary issue related to implementation includes creating efficient systems and operational workflow to administer IV iodinated contrast safely. So this is just a summary of all of the supplemental tools from ultrasound and MBI, contrast-enhanced mammography, and full MRI and abbreviated breast MRI, really looking at the cancer detection rates in these and just comparing them, and the false positive recalls as well. So when we look at supplemental screening tools, we have to look at potential adverse outcomes. Now, there's always that debate of overdiagnosis and overtreatment. Are we finding cancers that if we didn't find, they would remain, dormant in the breast, they wouldn't grow, and otherwise the patient would never know they had a breast cancer and they wouldn't have died from that breast cancer. Well, the argument that many of us have is if there is a breast cancer in the breast, we don't know which cancers are going to be more biologically aggressive than others. So it's hard to say, just leave that cancer alone that's in the breast. You really need a tissue diagnosis. There needs to be intervention to know what you're dealing with the cancer. So, the overdiagnosis and overtreatment has kind of been, in our field sort of debunked over the years. Although we still, it's a hot debate, in the field of medicine in general. False positives, I think we've improved that. We still see false positives with MRI and with ultrasound, but I think that that's significantly improved just with the quality of imaging we now have today. Patient anxiety is also something that we always consider, but we know that, of what's published in the literature, that usually that patient anxiety is short-lived. Just the cost of additional screening, though, I mean, that is something to consider, both monetary and labor costs. We know there's a shortage of radiologists in this country, technologists in this country who are available for supplemental screening for every woman with dense breasts. And for example, after the New Jersey dense breast legislation was passed, there was a 176 to 335% relative increase in screening breast ultrasound. And the increased direct costs for insurers increased from 4.9 million to 9.8 million per month. And that was reported back in 2015. So switching gears now to breast density legislation. So breast density legislation began with Nancy Capello. She was the former chief of special education in Connecticut. She was informed she had stage 3 breast cancer after normal mammogram. She was not told that she had dense breasts. So the Are You Dense movement was established by her in 2008 and her husband, as well as a grassroots advocacy effort. And in October 2009, Connecticut passed Public Act 941, which required radiologists to communicate breast density information to patients for both screening and diagnostic examinations. And then from 2005 to September 9th of this year, 39 states and the District of Columbia enacted some form of breast density legislation or breast imaging that included breast density language in various forms. So it varied all across the country, anywhere from discussing the percentage of women that have dense breasts, explaining how dense breasts can obscure masses, encouraging dialogue between the patient and her primary care provider regarding supplemental screening, and speaking directly with the radiologist who interpreted the mammogram. But this legislation did not require states to notify a patient of whether they did have dense breast tissue or didn't have dense breast tissue. So we passed breast density legislation in 2015. This was, before my clinical practice time, like right before. I don't know the origins of how this came to be, but I do know that there was breast density legislation passed. The problem with Missouri's dense breast legislation was that obviously did not tell the patient whether they had dense breasts or not. This blurb got, included in the patient lay letter and, created a lot of confusion with referring providers of what to recommend to patients. And I think that we in the field of breast imaging didn't have a lot of guidance and clarity on that either back in 2015. So over the years, there has been legislation introduced to at the federal level when it comes to breast density and making sure that patients were notified of their breast density across the country, because of course there were some states that still didn't have breast density legislation, and it just kept failing at the federal level. And then switching gears a little bit to the FDA and MQSA. So, and how did they come into the scene regarding breast density? Well, the FDA, with input from leading organizations such as the ACR, established MQSA in 92. And this was established because there really was a lot of issues when it came to mammography quality up until that point. So this was developed to ensure standard mammography quality across the country through enforcing strict accreditation, certification, and inspection of equipment and personnel at mammography facilities. And breast density notification was not in the first iteration, as we know. So, mammography in this country is highly regulated now. Leading up to 92, it was not. And so the quality has really, really improved over time, and really with the impetus of the passage of MQSA. So, in recent years, Congress was really not trying to pass any legislation on breast density because they knew that the FDA had something brewing with amending the final rule of MQSA that was going to include breast density reporting. So that was issued, the announcement on March 10th, 2023, with the rule to go into effect on September 10th of this year, where we needed to also notify our patients whether they were dense or not dense, include the language that they had for us to put in the patient lay letters. So now we're dealing with some issues in states where we have existing breast density legislation, and the language that we are required to put in the patient lay letter is incongruent or confusing when you compare it to the FDA language. But we're still required to put the state language in the lay letter because it hasn't been rescinded yet. So now we're dealing with that in many states, and we're dealing with that in Missouri. So we have to include this language here in particularly the FDA has this language that is here in blue that we have to put into the patient lay letters now, which is great. It says whether you're dense or not dense, and if you need to talk to your provider about supplemental screening, if that's right for you. So this last legislative session in Missouri, we tried to get the Missouri language rescinded because, again, it's very incongruent in comparison to the FDA language. And the bill died because, unfortunately, it was kind of clumped with a women's health bill that was very, very contentious, with very contentious issues in that bill. So the whole thing died. So now we are introducing it again this legislative session to try to get our Missouri language rescinded. So we only have to put the FDA language in the patient lay letter. So for this year, we have to include both the FDA language and the state language, which other states are unfortunately still having to do as well. So this is an example of the actual dictated patient report. So we're all required, and many of us have already been doing this, but to include the tissue density. But there were some, practices and institutions that still weren't including the tissue density, but now they have to. So this is an example of a patient who's heterogeneously dense. Now, when it comes to supplemental screening, that really varies per institution about whether they suggest it or not. They don't say anything in the dictator report. They just put the FDA blurb or whatever they're required to in the patient lay letter and just, leave it in the hands of their primary care providers. We actually put this blurb under impression number 2 in the report because we've worked with our primary care providers and OB-GYNs who want this in there. Also, when a patient is dense, we give them a pamphlet that I've put together in our breast center, so that the patient has the information about breast density, why it's important, and if they want supplemental screening, how do you get that scheduled? So we've worked really closely with our referring providers on this, and I think that was really imperative, and also to help educate them. I think they really appreciated it. So I encourage you, if you're going through some growing pains with this at your institutions, talk to your primary providers. They're the first frontline physicians that are meeting with these patients. Work with them, see what works for your institution to make sure the patients are getting educated. And if they do desire supplemental screening, they know the proper channels to go about it to have that exam done. So this is an example of a dictator report where the patient's not dense. And of course, for this one, we don't, suggest anything in terms of supplemental screening. So this is the pamphlet that I put together at our breast center. And, this is something that we give to patients who are dense. So they'll take it home. And then if they want to, schedule, it has the information for scheduling, but it's been really great. And then we have additional resources if they want to learn more. But, our technologists have been really helpful in being a part of the team to really educate patients on breast density and giving them this information as well that they can take home. So this is an example of our patient lay letter. So what we decided, since we have to include, obviously the FDA language, and we still have to include the Missouri language, we're basically putting the FDA language at the top, so hoping patients read that, and we're burying the Missouri language at the bottom, because again, we feel this is, incongruent, and hopefully this upcoming legislative session, we will be able to rescind Missouri language, and this whole big blurb at the bottom we can get rid of. So what's currently happening in the state? So it's, what's happening in Missouri. We're trying to rescind our existing breast density legislation. But there are some states that already were successfully able to sunset existing stipulated language, which is awesome. But there's so many states that are at different phases of this right now. So just because September 10th has passed us, there's still states that are trying to get their language sunsetted. There's some states where their language sunsets in January. But then, at the bottom here, there's many states where they prior to this final rule had no breast density legislation passed in their state. So they're kind of, more fortunate in the sense that they are basically starting from scratch, and they just have to include the FDA MQSA language in their patient lay letters, and they don't have to go through all this that we have to in states who previously had breast density legislation. So as you can see, there's a lot of variability in what's happening with the states when it comes to this. So how have physicians responded? Well, primary care physicians, they still may be unsure how to explain the risks and benefits of supplemental screening and the concept of dense breasts. So, I really, am a fervent believer that you really need to talk to your providers to make sure that they understand what this is, and so they can appropriately educate patients. I also feel that we should be taking a greater role, even though, we're busy as well, but talking to patients about breast density if they have questions, and our technologists as well. So, I think that, previously it had been reported that many women were still unaware of what breast density is. I think now that all states are required to include this in the patient lay letter, and there are breast centers that are going more above and beyond and educating patients on breast density, I think that that will really change in the years to come. It's important to remember there's varying levels of state insurance coverage for additional screening. So like in Missouri, patients who are above average risk, supplemental screening should be covered, but that's only if you have insurance under the state of Missouri. If you don't, you may not be covered. And then if you're a woman who is average or intermediate risk with dense breasts, there's nothing in the Missouri legislature right now that says, or the legislation that says that insurance has to cover these patients. So we still have a ways to go. We're making these recommendations. The MQSA final rule comes out, but yet we don't have coverage for all women. So that's something that we are working towards. And then women may not have access to different types of supplemental screening techniques based on factors such as geographic location. So where can we potentially improve education? So, research in the past has shown that many PCPs are really uncomfortable talking about breast density and its implications. So I think it's important for us to get them comfortable, right? So we can only reach as many patients as we can reach, but it really takes a village to educate these patients. So going and talking to your providers, talking to your OB-GYNs, your primary care docs, your internists about this is important. So knowledge is power. Stressing the importance of physician education, particularly PCPs who are most likely to address patient concerns of screening, like we talked about. A lot of times they're the front line for us. I'm a huge believer that radiologists and technologists, our technologists, really need to take a greater role in discussing breast density with patients, so they can make an informed decision when they decide on supplemental screening. And it's also important for us, our technologists, our primary care providers, to convey to patients and also PCPs when we're educating them on the subject that breast density is not fixed, and it can change over time due to interpreter variability. For example, if you're not using an objective software that calculates your breast density, physiologic changes to the breast over time, and differences in positioning. So Crescent's been doing a lot of research about patient understanding about breast density. So this was an article in 2016 where they found a wide variation of understandability by patients in 23 states analyzed. most having readability at the high school level or above, poor understandability and discontinuity with states' average literacy. Crescent published another article in 2022 where they conducted a national telephone survey with a little over 2,300 racially and ethnically and literacy diverse women, 61 of whom participated in in-depth qualitative interviews. Most women preferred learning about their breast density and the risks from their providers rather than letters. And these findings were more prevalent among non-Hispanic Black women compared to non-Hispanic white and Asian women. The opposite was true for women with low literacy who prefer written notification over personal, which I thought was interesting. And then women with really high literacy most often favored learning of the results via an online portal. And then the researchers also noted that women with low literacy, or those who do not speak English as a first language, they might prefer having a handwritten notification as backup if they're unable to process verbal communications confidently. So right now we're working on with particularly our supplemental screening pamphlets, having them in different languages for patients so that if they don't truly understand English well, they have that in their own native language. So very quickly, as we, are suggesting and more supplemental screening is happening, quality definitely matters, and especially for ultrasound. So, these were ultrasound images from an outside facility where, you just see a lot of shadowing. You're not really sure, could there be a mass there? I'm not quite sure, particularly on this image. There's just a lot of shadowing going on. And then this was also, measured, but then it's like, well, what's the shadowing next to it, to the left of it? It's just hard to really tell. But then looking at these ultrasound images from our facility, clearly I see that there is a malignancy here. So, I always, especially if we're going to be offering supplemental screening at facilities, when it comes to an ultrasound modality, the quality, the technique, it most certainly matters for these patients. We want to try to find these cancers when they're really, really small to ensure that they have an excellent prognosis. So where are we going with the future of breast density? So some of you might have heard, the Find It Early Act is federal legislation that's a bipartisan effort from Representative Rosa DeLauro and Brian Fitzpatrick. And that would ensure all health insurance plans cover screening and diagnostic breast imaging with no out-of-pocket costs for women with dense breasts or at higher risk for breast cancer. So that is currently reintroduced in the House. There will be, and you might have seen, there's been a call to action that has gone out to support this legislation. The American College of Radiology will be sending out a call to action on this soon. So if you do receive that email to respond to your federal elected officials, please do on this, as we're trying to fight for coverage for all women across the country. However, this bill is seen as costly when trying to achieve budget neutrality, but we will continue to push for coverage across the country. And, just like breast density, we saw all these states that passed legislation, and then finally we had federal sweeping legislation through the FDA. Well, the same happen here with with coverage for these patients, and we're hoping so, because we're seeing more and more states passing their own coverage for above average risk women, diagnostic breast imaging legislation without copay or deductible. States are doing this. Hopefully we'll finally have federal sweeping legislation so no woman is left behind. So with that, I want to say thank you for your time. I'm happy to answer some questions. I see some things popping up in the chat. I can look at that as well, but thank you so much.
Yes, thank you so much for sharing your lecture with us today, Dr. Patel. At this time, we will open the floor for any questions from our audience. You may submit your questions through the Q&A feature. And yes, we've got a few questions in the Q&A.
Okay, I'll take a look here. Okay, this is a good question. If we are a small breast imaging center, what is the one supplemental tool that we can add that will use our resources the best and not strain our schedule and staff? Mainly, question is if we should offer handheld ultrasound or MRI. We probably would not buy ABUS. We already have DBT. That's a really great question, because as a medical director, I feel the strain, and whether it's a small center, a large center, a medium-sized center. And this is something we are constantly having issues with staffing, with scheduling patients, issues with scheduling. It's kind of a nightmare. So my answer to you would be, I would sit down with your team and see where you have the best bandwidth. For us, and looking at the literature, we have pushed for abbreviated breast MRI as the first line because of what we're seeing in the literature, and particularly with the sensitivity, using ultrasound as a backup. We also do not utilize ABUS, but as a result, our MRI volumes have exponentially increased since we have offered abbreviated breast MRI about 2 years ago is when we started. So making sure we had the staff bandwidth to do that was important, and making sure we had the appointment slot times that we could get these patients in a timely fashion was important as well. So I think it really is institutionally dependent. Where do you see on your schedule, where do you see with staffing where you can offer this more readily than others? But no doubt, I mean, this is causing a crunch on workflows, whether it's an MRI, whether it's an ultrasound. I really wish it wasn't as murky as it is, but it really, I think, is institutionally dependent on where you see your bandwidth. And then also other things too, like some institutions want to have abbreviated breast MRI and offer to cash pay, but then it might be taking forever to get to that agreement with the health system of offering cash pay. I mean, there's just so many layers to this. So I think just working with your team, seeing where you see the potential bandwidth, working with your finance team at your health system to make sure that they're okay with this moving forward with whatever modalities you offer, I think is important, because that's what we did when we embarked on this. Ugh, what a question. If I had it's like $1 million question. One of the questions is, can you tell me how we can accurately diagnose suspicious lesions in case of marked background parenchymal enhancement in breast MRI? Woo! Breast MRI can be so challenging to interpret. And then you get hit with marked background parenchymal enhancement, and it's so hard to know what do we go after, right? So, for me, I really try to, and I'm a breast specialist. I don't read anything else but breast, and I've been that way since I came out of training. For me, the things that I remember and try to think about is, is there a morphology of one of these areas that are enhancing that look differently from the rest of the BP? We learned that morphology trumps kinetics. So using that kinetic mapping can help. But I I don't hang my hat on kinetics, although it can help, particularly in the setting of marked BPE. But really looking at the morphology of that area of enhancement, does it look differently from the rest? And sometimes it's just hard to make the call. You might overcall, you might do the biopsy and it's a being benign, or you might undercall. You might just give it a BI-RADS 3, but it ended up being a malignancy. So it can be very, very challenging. But those are sort of the things that I try to do. Is this one area of enhancement, maybe it's more avidly enhancing, and, again, is the morphology looking more suspicious than other areas in that breast tissue? And then, of course, I try to use kinetics as sort of as a backup sort of tool in my diagnostic, in my diagnosis of what I think something is. So, okay. All right. I think we're good.
All right. Thank you so much, Dr. Patel, for taking the time to share your lecture and expertise with us and to answer everyone's questions. So thank you so much.
Thank you. I appreciate it.
All right, and be sure to join us next week on Thursday, October 24th at 12 p.m. Eastern, where Dr. Stephen Pomeranz will deliver a lecture entitled MRI of the Hip. You can register for it at mrionline.com and follow us on social media for updates on future noon conferences. Thanks again, and have a great day.